Welcome to my channel. Thanks for visiting. Remembering to subscribe, sharing my presentations, and listening to all of them. Today, we'll be addressing atrial fibrillation. Some will abbreviate it to AFib or AF. This will take us through what is atrial fibrillation. Is it different from other arrhythmias? What are the possible risk factors? What are the symptoms and the signs? What should be at the back of our mind while taking the history? What are the differential diagnoses of atrial fibrillation? The physical examination should involve what? What are the investigations? In acute condition, what should we do? How do we treat? Are there preventive measures? Are we going to be faced with long-term complications? All the answers to these questions are right here. Arrhythmias. When it comes to arrhythmia, it's just like any part of the body becoming sick. So in this case, the heart is sick, but it's not heart attack, it's not cardiac arrest. It is sick because there is trouble with the electrical activities within the heart itself. Majority of people will pay attention to the heart rate, but arrhythmias might be abnormality or abnormal rate or abnormal rhythm, and can be both. When it comes to the rate alone, it might be bradycardia, meaning the heart rate is slow, or tachycardia, meaning the heart rate is fast. The brief physiology of electrical activities of the heart is such that Sinoatrial Node is the heart pacemaker. It is located at the junction of the superior vena cava and the right atrium. When the electrical impulse is propagated from that sinoatrial node, there will be action potential leading to depolarization of the atrium. And then the journey will not end there. The impulse will be passed to AV node. The AV node will connect the true atria, that is right atrium and left atrium, to the ventricles with the help of bundle of His. The bundle of His cannot reach the ventricle by just one route. It will divide into right bundle branch going to the right ventricle and left bundle branch going to the left ventricle. And that will also connect the vesicular branches respectively. So the entire ventricle will be wrapped up in Purkinje fibers. So the final impulses will reach the ventricle, both the endocardium and the epicardium, with the help of Purkinje fibers, leading to rhythmic contractions of the ventricle. That is essentially how the electrical activities of the heart will be propagated by sinoatrial node under normal circumstances, leaving us with sinus rhythm, but we will see in a bit when we can see aberrations. Okay, here is the image of the heart. Here you can see that we have the pulmonary artery from the right ventricle going to the lungs, and then from the lungs, pulmonary vein bringing the blood back to the heart, and then this is the aorta, right? And this is the ventricle, okay? And you could see the coronary arteries. The heart. We will understand this subject better when we go through this very slide thoroughly. Okay, So don't be in a haste. You can see that we've opened up the heart, right? And we can see what is happening inside, because that is where the problem is. To start with, the journey of 1,000 miles will start with a step, right? This is the inferior vena cava, bringing used blood, deoxygenated blood, from the lower parts of the body. This is superior vena cava, bringing used blood, deoxygenated blood, from upper parts of the body. They will both empty into this right upper chamber called right atrium. At the junction of the superior vena cava and the right atrium is the Sinoatrial Node, the heart pacemaker. Let me go through the pumping activities first, and then I'll come back to the electrical activities. When the blood is here, what is expected is that it's going to pump. This chamber will pump the blood into the right ventricle. The right ventricle is expected to pump the blood into the pulmonary artery. It is called pulmonary because it's going to the lungs, and it's called artery because it's taking blood away from the heart to the lung. Inside the lung, we know what is going to happen. Oxygenation, right? The oxygenated blood, not deoxygenated, oxygenated blood will come from the lungs into the heart on the left. This is the left atrium. And any vessel bringing blood back to the heart is a vein. So pulmonary vein from the lungs will bring oxygenated blood to left atrium. It will not just be sitting down there, it will be pumped into the left ventricle. The left ventricle will pump the blood into the aorta through aortic valve. Some people will have aortic stenosis and they will come down with certain signs and symptoms, fainting, syncope, falling. No, that will be for another day. Okay. Then from there to the ascending aorta to arch of the aorta, these ones will supply the head and neck region, and then descending aorta, and then abdominal aorta, and so on. You could see that the ventricle is thicker compared to the atria. See the left atrium, the right atrium, see the wall. Okay. Now, as per the electrical activity, what is the issue? The sinoatrial node is expected to generate the impulse, the electrical impulse. But in atrial fibrillation, we have a problem. The normal sinoatrial node activity here has been overpowered by aberrant foci all around. And then instead of the action potential that will lead to depolarization here, that will give us good pumping force that will push the blood into the ventricle, there will be quivering. Instead of one strong squeeze that will force the blood here, we'll see many quivering, not just fibrillating, quivering. It's not really, having enough force to contract in a strong way to pump the blood into the ventricle. So with that, the heart will fail because enough will not get to the ventricle, enough is not getting out. The same thing on the left, the blood is here, enough is not getting into the left ventricle, enough is not getting to the aorta. So that's why we'll be dealing with heart failure. Remember also, when the blood has been dumped here in the right atrium and it's just there for a long period of time, remember clotting factors are also included, platelets are there, then clot formation will occur. And remember, when clots are formed here, and later on part of it is taken into the lungs, we'll have problem like pulmonary embolism can occur, and If the clot is coming from the left side into the aorta, that will give us stroke, right? Remember, these ones I said will go up to the neck and the head, that is the brain, okay? So we have seen that atrial fibrillation is a serious matter because it's going to reduce the activity, the force, the efficiency of both right atrium and left atrium, giving us atria. Two of them is atria. That is why the name atria. And the name fibrillation means instead of full contraction that will pump the blood to the right ventricle here and the left ventricle here, is just going to be quivering or fibrillating. So we can now see fully how we can run into trouble with atrial fibrillation when the sinoatrial node is being overpowered by the unwanted foci around. Still on AFib, atrium is one upper chamber. The two is atria, meaning we are dealing with the two chambers in trouble today, and the trouble is electrical activity. We know the ventricles, I've just shown them. We've seen the pulmonary vessels, I've shown them, and we've seen the aorta. Here in atrial fibrillation, there will be abnormal, rapid, chaotic heart rate. It's going to be abnormal and it's going to be rapid. So not giving enough time to pump enough into the ventricles, and it's going to be chaotic, just quivering and fibrillating. Occurring in the atria, but the ventricles will respond. We'll go into ventricular response later. I have decided to make this very bold because the medical students, the nursing students will want to hear the word irregularly irregular. That is pathognomonic of atrial fibrillation. The reason is that there could be atrial flutter. Flutter is not irregularly irregular, okay? It's only atrial fibrillation that is irregularly irregular. Here, like I've just explained, there will be inadequate pumping function of the heart. And what is that telling us? There will be heart failure. When there's heart failure, blood is just sitting down there with platelets and clotting factors. There will be clot formation and subsequent stroke. I hope that you won't mind my sketch. I'm not a good artist. You can see that this is P wave. This is QRS complex, and this is T. I'll be limiting myself to P and QRS complex today, because that's what we need for atrial fibrillation. Now, if we go through lead 2, this P wave should be upright. If it is upright and it is lead 2, it means that the impulse is from Sinoatrial Node. So it is called sinus rhythm, okay? And what this P wave is indicating is that there is Atria Depolarization, meaning the atria or the right and left atrium, meaning the atria, two of them, are contracted, okay? The action potential would then spread to the AV node. Then from the AV node, with the help of the bundle of phase, right and left bundle branches to the ventricles. Each P wave here is expected to be followed by QRS if there is no blockage along the line. The P is widened in atrial enlargement, and the P wave amplitude could also increase in atrial enlargement. In atrial fibrillation, we might not be able to identify P. In fact, we will not be able to identify P. Now, let's go more and see what's happening with electrical problems that could be diagnosed with the help of EKG. We'll go into that in a bit. Like I said, the P is for atrial depolarization. The QRS is pointing to ventricular depolarization. I will not go into details of TST segment, U wave, QT. This is a link if you want to see that. There I've explained everything about ST elevation and 30 causes of ST elevation. Now, let me go back to the PR segment here. The PR segment is the end of P to the onset of QRS. Okay? Here there will be slow, you could see that this is isoelectric. So there is slow conduction through the AV node. That is what is happening here. Okay? Remember, with the help of AV node, we'll connect the ventricles, right? And the impulse conduction through AV node this time is this, so there's no depolarization occurring. Okay? The PR segment could be depressed in pericarditis or atrial infarction. Okay? And the PR could also be elevated in AVR under pericarditis. Okay. Now, the PR interval. The PR interval is the onset of P to the onset of QRS. You could see the P to the onset of QRS. Some will label it as the onset of Q. That is just a matter or a function of time. Time between atrial depolarization here and ventricular depolarization here. So, and that is expected to be 0.12 seconds to 0.20 seconds. So that is what PR interval is all about. So it's a function of time. It's a function of time. Okay, you can see again, this is the P wave, the PR interval, the PR segment, the QRS. Okay, now you can see something here. Who will tell me what this is telling us? You can see that we cannot really pick out the P wave here, but we can see the R wave, meaning this is the ventricular depolarization, QRS complex. Okay, you can see the R waves, but you cannot see the P wave. This is atrial fibrillation. We'll see that when you look very closely, these RR waves are not constant. No, they are not regular, and they are irregularly regular, because if you see the distance here, see, and see this one, see again, so there's no regular pattern. It's not that you will see these two close, a wide gap, and then the space between this and this is not equal to the space between this and this. So it's irregularly irregular. The normal electrical impulse pathway. Someone will say, why are you going over it again? It's necessary so that we can know the trouble we are running into with atrial fibrillation. Sinoatrial node is at the junction of the superior vena cava and right atrium when we are dealing with sinus rhythm. And that is where the electrical impulse will be generated from. And from there to AV node, and from AV node with the help of bundle of His to left bundle branch or right bundle branch, these will transmit the impulse to the vesicular branches. Then from there to respective Purkinje fibers, that will reach the endocardium and epicardium at the apex. And lastly, the right and left ventricular contractions will occur. Now, abnormal electrical pathway when it comes to AFib. Okay, in atrial fibrillation, we'll be dealing with rapid impulses from Sinoatrial Node that is overpowered by aberrant automatic foci within the atria or pulmonary veins. We can now see where the trouble is, leading to irregular atria rhythms, not ventricular rhythms, irregular atria rhythms. In atrial fibrillation, the ventricles will respond. So let's have a look at ventricular response to atrial fibrillation. The response may be control response, meaning there's reduction in the ventricular rate with increased diastolic filling, and expectedly, the left ventricular ejection fraction will be high. So, cardiac output versus ventricular rate output slope will be positive. But that may not be so fast if we are dealing with decrease in contractility and the beats per minute is so slow, even with control response. So what I'm trying to say is, though the ventricular rate is not as fast as the atrial rate, but if the force of contraction is not strong in the ventricle, and the rate at which the ventricle beat per minute is so small, we will not have high left ventricular ejection fraction. In summary, as per the control response is time control response when ventricular response is about 90 beats per minute. So RR is giving us 90 beats per minute. It is time to be uncontrolled when there's a rapid ventricular response giving us RR that is greater than 140 beats per minute. In that case, we'll be faced with the full signs and symptoms of the atrial fibrillation, from chest pain to palpitations to shortness of breath. In a nutshell, the individual will become unstable. Then we need to add fast. Now, atrial fibrillation. Do we have different types of atrial fibrillation? Yes, of course we do. Okay, let's go through them. The first episode of atrial fibrillation could be tagged first AFib. If that is the case, the individual is having this problem for the first time ever in life. Here, we care less about the duration or the symptoms. All we are saying is this is the first time Mr. AA is having AFib. So first episode of AFib. We can put that on the card or on the record. When somebody is labeled as having persistent AFib, meaning what? Meaning that he or she has greater than 7 days of atrial fibrillation, and it is no longer self-terminating. So this type can only be terminated with cardioversion medically or electrically. Don't worry, we'll go into all this cardioversion later on. Okay. Another type of atrial fibrillation is lone atrial fibrillation. Let me say the truth here that this is controversial. American Heart Association and European Society of Cardiology, they are concerned about this definition. But European Society of Cardiology has clearly come out to say, no, we will not use this definition, okay, this name of low atrial fibrillation. But to those who still go through this in the literature, low atrial fibrillation is occurring in younger age group. Example would be somebody that is 60 years or less. And another thing is there is no family history and no personal history of atrial fibrillation at all in this patient. Also, for you to say this is a lone atrial fib, there will be no any related heart disease, no lung disease like COPD, no metabolic disorder. All investigations, including echo, if you like do transthoracic, if you like do transesophageal, there will be no structural anomalies. Sometimes can be asymptomatic. It means you can have this lone AFib and you're not even aware. And then you ask me, if I have it and I'm not aware, then how will you know? Well, it could be picked up accidentally when we are investigating you for something else. So accidental discovery during routine investigations. All other symptoms of AFib may be present in some people with lone AFib, but you have done everything, you are not finding heart, lung, or metabolic anomalies. Symptoms are sporadic in lone AFib. It will last for a few minutes and return again in the next few days or weeks, and sometimes might be in the next few months. It is labeled as lone AFib if there is atrial fibrillation in younger people and there is no cause or causes identified. Still on different types of AFib, Parasysma Afib is also called intermittent AFib. It means that this will reoccur suddenly, lasting for less than 24 hours, but if it is greater than 48 hours, then you need anticoagulants, okay? Why that? It may not spontaneously terminate, and it may not return to sinus rhythm. That is meaning of being, spontaneously terminated, okay? It abates and to reoccur again. It terminates spontaneously in less than 7 days with or without treatment. There's no life-threatening situation here, but it is dangerous. And it may also lead to heart failure or stroke. Recurrent atrial fibrillation is the definition when we have greater than 2 or more episodes of AFib. Long-standing AFib will be the name when AFib is in that patient and is there for greater than 1 year. Permanent atrial fib is also known as chronic AFib when it is greater than 1 year or many years and it is not aborted with cardioversion or there is failed cardioversion. But the patient will not be left without being helped. He or she will be on anticoagulants and medications to handle the rate. So rate control and anticoagulants in permanent or chronic atrial fibrillation. What are the possible risk factors associated with atrial fibrillation? Age. And somebody is asking me, and how about that? The chances of having atrial fibrillation increases with age. Lone AFib will occur in 60 or younger. Diabetes mellitus is a big, serious risk factor. Coronary artery disease like myocardial infarction is a big risk factor. And remember, diabetes mellitus can give us coronary artery disease, as in macrovascular complication of diabetes mellitus. Hypertension that is not under control is a risk factor. Obesity, that's why we need to shed weight. Obstructive sleep apnea. Thyroid problems like hyperthyroidism or thyrotoxicosis. Still on risk factors, surgery, particularly cardiothoracic or abdominal surgery. Pulmonary embolism, that will have bidirectional kind of relationship. Heart defects, rheumatic heart disease, heart failure, valvular heart disease, cardiomyopathy, lung disease, for example, chronic obstructive pulmonary disease, alcohol, cocaine, other street drugs. Other risk factors for atrial fibrillation will be genetics. And why that? Positive family history of atrial fibrillation is a strong risk factor. Medications like sympathomimetics, smoking, coffee, systemic inflammatory or autoimmune diseases, emotional stress, overexertion. Still on risk factors will be acid-base disturbance, pericarditis, Wolff-Parkinson-White syndrome, electrolyte anomalies like hypokalemia or hypomagnesemia. What are the possible symptoms of atrial fibrillation? Palpitations, the heart will be beating fast, lightheadedness, fatigue or tiredness, syncope, dizziness or fainting, chest pain or pressure in the chest region, shortness of breath, edema, that is, pedal edema or periorbital edema. What are the signs? That's what the EMS, the doctors, the nurses will pick on physical examination. Patient will be dyspneic, be having shortness of breath. The heart rate will be pretty fast, low blood pressure, and the patient will appear very weak or lethargic. How do we know whether this patient can come down with stroke or not? So we want to check out for the risk of having stroke in atrial fibrillation, and we'll do that through chart 2. That means C for congestive heart failure, that will be 1 point. H for hypertension, 1 point. Age over 75, 1 point. Presence of diabetes mellitus, 1 point. But stroke or transient ischemic attack in the past will give us 2 points. Still on risk assessment of stroke in AFib, you can have CH2, DS2, VAS. In that case, C is for congestive heart failure, hypertension, age over 75. This time will be 2 instead of 1. DM will remain 1. Stroke or TIA in the past will give us 2. In addition to all this is history of vascular disease and age 65 to 74 or being a female. We've seen the heart again. We've just gone through chart 2 and chart 2 DS2 VASC, risk determination of stroke in AFib, right? Remember this. Remember the explanation already given. Just in a bit. Remember that when the blood is dumped here from superior vena cava and inferior vena cava, and instead of full contraction, that will force the blood into the right ventricle and take it to the pulmonary artery and to the lungs. That's not happening in atrial fibrillation. Instead, there's quivering and fibrillation right here, meaning less blood will be pumped into the ventricle, more will stay here. With the platelet aggregation and other clotting factors, then clot formation will occur. And when that breaks and comes here, and then that is pumped out. Okay, the same here, and whatever clot is formed here would then be pumped into the aorta and then to the brain. That is how the stroke will occur. So CHAS2 and CHA2DS2 VASC, if you've used either, when the score is 0, then there's low risk of stroke. But when the score is 1, that means the individual has moderate risk of stroke. When the score is 2 or greater, the individual has a high risk of stroke. But CHA2DS2 VASC, this one, will lead to more people being categorized as having a high risk of stroke. Well, to me, that should be an advantage to be able to keep an eye on them more and help them more than for us to think that they have 1 or less than 1. Okay, we will take history, right? Then the history will start by what's happening. The patient will say, my heart is racing. Okay, then we'll tell the patient, can you tap on the table for me, please? Describe how the heart is, beating, if you can. Then you pick that. Then we'll ask, when has this started? Onset of the symptoms, the cause of the symptoms, whether it's getting worse or not, and for how long. Then we'll go through each of the symptoms again. You can go back to the list, like palpitations, shortness of breath, chest pain, any cough. What's the characteristics of the cough? If we're ruling out phrygmocytoma, then the situation will be sudden with headache, and the BP will go up with fast heartbeat and sweating. Any infection that is ongoing associated with fever, high temperature, and sometimes it can be even hypothermia, right? Any psychiatric disease like panic attack, with or without agoraphobia. Then do you have diabetes? Are you on any medication right now? And what's your diet like? Any exertion? Do you think there's low glucose? We can even test or ask for symptoms of hypoglycemia. Thyroid, we want to rule out hypothyroidism or thyrotoxicosis. Are you, disturbed with heat more than necessary? How about more cold than necessary is hypothyroidism, right? Okay, we want to go to differential diagnosis of atrial fibrillation now. It could be panic attack, could be anemia, could be hypothyroidism, could be thyrotoxicosis, might be heart attack, and could be pheochromocytoma. It might be because this person is on cited medication like atropine, salbutamol for asthma or COPD, or for any other reason you are taking it anyway. Could be because you are on tricyclic antidepressant, or you are on adrenaline or epinephrine, depending on whether you are in Europe or in North America. Do you have pacemaker insertion that is misbehaving? Have you lost fluid recently or decreased intake, and then you are now dehydrated, maybe vomiting or sweating profusely, or because of the weather? Hypoglycemia. We'll go through the symptoms of hypoglycemia with patient. Are you on coffee often, or just taking coffee for the first time, and then you are down with this now? Are you pregnant? A woman of childbearing age, you want to know. We just say, woman chronic gonadotrophin. Fever because of infection, or fever because of dehydration, fever because of certain medications? We want to know. Street drugs. Now, I pray they'll be honest enough to let us know about this, like cocaine, amphetamine, and so on. Other arrhythmias might be the problem. You may not be able to tell us, but the EKG will reveal that. Then it might be other supraventricular arrhythmias or none. We might be dealing with slow ventricular response, meaning the heart rate is less than 60 beats per minute. And in that case, we should be thinking of certain stuff. Like what? Hypothermia, sick sinus syndrome, digoxin toxicity, or already on treatment for AFib or something else. Now, the physical examination. We'll have thorough cardiovascular system examination. We'll have respiratory and peripheral vascular examination. Now, investigations to be done. First thing first, EKG. Thyroid function test done. Remember, we were talking about hyperthyroidism or thyrotoxicosis. You can have echo, transthoracic, but preferably transesophageal echo. Chest X-ray, glucose. Now we're talking of hypoglycemia or diabetes mellitus, right? Complete blood count, anemia, or infection. Pregnancy test, electrolytes, not dealing with hypokalemia or hypomagnesemia. Both can lead to prolonged QT syndrome with subsequent arrhythmia. Toxicology, because we're talking about street drugs, amphetamine or cocaine, and so on. Vanillin mandelic acid for pheochromocytoma, lipids, and liver function test. Now, this is the EKG that I could lay my hands on, for getting out of copyright issues. I cannot just go and copy anybody's EKG and put it there. Okay, so I think you'll be able to make use of this. Okay, if you look at this, and this is R waves. Okay, for KRS complex. We cannot find P, but we find KRS complex and R wave. If you see the gap between the RR, it's not the same, right? Like, you see the gap where the big buses. If you count the big buses, there is about 2.5 here, and 2, then almost 3 when you add this, this, and then here you have, have 1, 2, 3, 4, and 1, 2.5. Then here you have 1, 2, 3. You have 1, 2, 3, 4, 1. So it's irregular. So just to portray what I've just done, remember the PQRS, that normally the P should be followed by QRS, but now we can't even identify the P because we are dealing with atrial fibrillation, right? We can't identify the P here. So that's what is happening here. So irregular. The ECG in Europe or EKG in North America, when it comes to AFib, will present with the following. Ventricular rate is mostly between 110 to 160 beats per minute. It is judged or tagged to be rapid when it's given 100 and slow when it's less than 60 beats per minute. The P waves will not be seen, no P waves. The region will be irregularly irregular, and the QRS complex will be narrow. The fibrillatory waves is known to be fine when it's less than 0.5 millimeters, and the fibrillatory waves will be coarse when it's greater than 0.5 millimeters. When it comes to the treatment, we should know what we want to do. We must be thinking about rate control, rhythm control. Will I use blood thinners here, that is anticoagulant? Will I use electrical cardioversion? Any need of catheter ablation, or is that what we'll end up with? Are there any underlying disease or diseases that must be treated? How about counseling as per lifestyle changes? So the treatment will be centered around all this. Okay, the patient is there, and this is acute treatment now. Is this patient unstable? Oh, am I asking myself? Yes. How can I provide the answer? Okay, I will find out. Is this patient confused? Having chest pain? Having chest discomfort or discomfort generally? Any pressure in the chest region? The BP is showing me that there's hypotension, dizziness, lethargy, features of heart failure, autopnea, paroxysmal notional dyspnea, edema. If I can pick that, the patient is unstable. Then I must have cardioversion done immediately. The patient that I've just treated is patient A. Now this is patient B. Their situations are not the same, though it's both atrial fibrillation. This patient B is stable, and this problem has started just in the last 24 to 48 hours. Anticoagulation is not necessary before you cardiovert, if you must cardiovert here. And you have to cardiovert when there are structural heart defects or cardiomyopathy. I will do all investigations now and have maintenance therapy. Patient C is stable, but the onset of this problem is greater than 48 hours. I have to give anticoagulant right now, and I will give that for 3 weeks. Then I will go to the second level, do cardioversion. I will continue other medications, and then I will give anticoagulant 4 weeks after. Xarelto or warfarin could be used for anticoagulation. Aspirin low dose 81 milligram for patients that are less than 65 years old and without any score when it comes to stroke risk assessment using CHART S2. If the score is 0, then give low dose aspirin for anticoagulation. You can use Xarelto instead of warfarin if this patient has positive coronary artery disease, aortic or peripheral vascular disease. For rate control, if there is a heart failure, we can use digoxin, amiodarone, but no calcium channel blockers. We can use beta blockers or non-dihydropyridine calcium channel blockers like D-Tazem. If we are not winning with beta blockers or calcium channel blockers, we can add low-dose digoxin. We must do our electrolytes when the patient is on digoxin, and why? Particularly the level of potassium. Cardioversion is necessary, even if the patient is stable and the onset is less than 48 hours under certain conditions. And the conditions will be if there is structural heart defect like valvular heart disease, we must have cardioversion regardless of the onset is less than 48 hours or not. And if there is associated cardiomyopathy in anyone with atrial fibrillation, even if the onset is less than 48 hours, even if the patient is stable, we must have cardioversion done. In permanent atrial fibrillation, but not symptomatic, we can use beta blockers and anticoagulants. Antiarrhythmic drugs are welcome. Amiodarone will be the best friend when we are faced with left ejection fraction dysfunction or myocardial infarction. In myocardial infarction, without left ventricular ejection fraction dysfunction, then we can give beta blockers. But once left ejection fraction is low, we can give amiodarone. We can also use propafenone or flecain. Now, the electrical cardioversion. Here, we will use synchronized cardioversion. And let me explain a little bit what synchronized cardioversion is all about. Here, low energy will be used, okay? There will be a sensor that will deliver energy only at the peak of the QRS complex. When defibrillator is presented and we go for the option that NYC Nassim's option, and then we pull the shock button, there will be a delay in the shock. Why that? The defibrillator will be waiting for the peak of the QRS complex. So the defibrillator will only shock when synchronized with the peak of the QRS complex. That is the highest point of the R wave. That is what is used in atrial fibrillation, not like the case is with ventricular fibrillation. Now, we can use 120 joule biphasic defibrillation or 200 joule monophasic. Prevention. Prevention, they say, is cheaper than cure. That is, if the situation is curable at all. First thing first, go back, pause, reflect on all those risk factors. Do you have them or one of them? Watch all the risk factors and address them. Catheter ablation is good for permanently stopping atrial fibrillation. We should use Child's score to determine the risk of thromboembolism and possibility of stroke. We can consider antithrombotic therapy if the risk is very high. Stroke. How do we get there? This is a silent cerebral ischemia, meaning non-symptomatic but revealed by imaging. Fibrillatory contractions will lead to stasis. The stasis will then, with the help of platelet aggregation and other causing factors, there will be clot formation. When the clots become dislodged or embolizes, then through the left ventricle to the aorta and then the brain, then there will be ischemic stroke. Yes, we've gone through how atrial fibrillation could lead to stroke, right? But let's enjoy this picture together and then refresh our memory. Superior vena cava is bringing blood from upper parts of the body, inferior vena cava from lower parts of the body, down in the right atrium. Normally, Sinoatrial Node will generate the electrical impulse leading to depolarization of the atrium and then pushing the blood into the ventricle respectively. But in atrial fibrillation, there's quivering or fibrillation, not full contraction. So loss of the blood will still be here. Stasis is occurring. And remember, we are talking about whole blood now, where platelets are present and other clotting factors, right? Then clot formation will occur. And with that, if it's happening here, to pump from here to the ventricle and break and then get into the blood, and then is pumped by the left ventricle through the aortic valve to the aorta, and this will supply the head and neck region. Then the individual comes down with ischemic stroke. Also from here, lead to pulmonary embolism. Pulmonary embolism and atrial fibrillation will have what is known as bidirectional association. Atrial fibrillation can lead to increased risk of pulmonary embolism through right atrium clot formation. Pulmonary embolism may lead to atrial fibrillation with right-sided pressure or inflammatory cytokines. Let me go through this again. When we say bidirectional, meaning both ways, no? Two sides of a coin, okay? Pulmonary embolism and atrial fibrillation were shaped in such a way that one will complement the other, but no human being will want either of them. Okay, I don't want pulmonary embolism. I don't want atrial fibrillation. The atrial fibrillation will increase the chances of having pulmonary embolism when there's clot formation in the right atrium. I just explained, just 2 minutes ago, right? Well, when there's pulmonary embolism, that will lead to pressure overload and inflammatory cytokines on the right side. So that will lead to atrial fibrillation. Now, the heart failure. When the atria are fibrillating instead of pumping, then returns from inferior canaveral and superior vena cava and pulmonary vein will not get completely into the ventricle. So there will be decreased ventricular filling. With decreased ventricular filling, we'll be dealing with decreased cardiac output and heart failure. Then we'll see signs and symptoms of heart failure: hypotopnia, cough, weakness, chest pain, hemoptysis, paroxysmal notional dyspnea, pedal edema, periorbital edema, third heart sounds, and so on. And of course, with heart failure, there will be decreased organ perfusion. Now, with time, leading to multiple organ failure and death. Okay, the heart failure issue with atrial fibrillation. Okay, let's study it together. We've gone through this animation and the stroke, right? Okay, the heart failure now. The blood is coming from inferior vena cava, superior vena cava into the right atrium. Enough is not pumped because it is quivering instead of pumping. Then there is stasis. So enough is not getting to the right ventricle, less is pumped by the right ventricle to the pulmonary artery, less is going to the lungs. Okay, whatever is coming from the pulmonary vein to the left atrium is staying here. Okay, instead of contracting fully and pumping the blood to the left ventricle. Just a little bit is going to the left ventricle. And it is that little bit that is going to the left ventricle that will go through the aortic valve into the aorta and to the entire body. So the heart is not sending enough to the entire body, so the heart is failing. The heart is failing, there's stasis here, there's stasis here. The stasis here will lead to backflow to where the blood has come from. So there's edema down here, Peter edema. Then here, there will be cough because there will be pulmonary congestion. That's why we use LASIS in congestive cardiac failure. There will be pulmonary congestion, then otopnea, paroxysmal notional dyspnea, because when they lie flat, the lung is congested, the person is coughing and coughing, okay? Then swollen face, because it's the enough that is reaching here is not getting out, so it's going back. And the same, there will be swollen face, and eyelid edema or periorbital edema and so on. So you can see some that we have hemoptysis, the congestion here, going back to the lungs is responsible. The long-term complications will be stroke from thromboembolism, heart failure, like I fully explained, and death. There will be increase in chances of sudden and non-sudden cardiac death from atrial fibrillation. So it's worth knowing everything about atrial fibrillation and treating the condition appropriately. Thanks for spending 1 hour of your life to listen to this presentation that may be helpful in saving some lives somewhere. I appreciate that. And to my French listeners, merci. Thank you. Thanks for listening. Remember to share this presentation. Remember to subscribe to my channel. Remember to give thumbs up. Remember to leave your comment. I appreciate it.